to the 81st session of the weekly huddle. My name is Anoop Agrawal. I am a cardiologist at Care Hospital, Banjara Hills, and joining me today is my friend and co-host Praneeth. You all are quite familiar with the format of the weekly huddle, so I'll skip the introduction and I'll directly go to the case for today. So this is a 68-year-old female. She was admitted to my service around 3 months back, where her presenting complaint were chest discomfort and breathing difficulties. She was actually pretty sick by the time she arrived to the hospital. She was treated in lines of non-attenuation MI and cardiogenic shock. She also seemed to have UTI, which was also treated. She had a prolonged course where she spent a few days in the ICU and a few days following in the room for rehabilitation. And I believe after about maybe 11, 12 days, she finally was discharged home. And at the time of discharge, her medical status was more or less stable. But of course, being in the hospital for close to 2 weeks, her physical status required a lot of work, including physiotherapy and whatnot. And she indeed was referred to cardiac rehabilitation, which she decided not to participate because of logistical challenge, because she actually was the primary caregiver to her husband. So, and they didn't have any particular help. In the last 3 months, she visited me a few times, and every time she came in a wheelchair along with her husband. And one of her friends who lives in the neighborhood, she came along with her. So this was, I believe, her 3rd or 4th visit. And this is 3 months after her index hospitalization. Her cardiac status is otherwise okay. She's not complaining of any major discomfort. She says that I'm slowly recovering from the illness which happened 3 months ago. She is able to carry out her daily activities at home, although whenever she steps out of her home, particularly coming to the hospital, she requires a wheelchair because she finds it difficult for her to walk for that long distance. Her main issue, other than just generalized weakness, is poor appetite. And I tried to be very explicit to her. Is it nausea? Is it abdominal discomfort or just poor appetite? And she pretty much mentioned that it is poor appetite. She just does not feel like eating. And her husband also concurred the same finding, that her food habits or the quantum of food that she was eating now was drastically reduced as compared to what she used to eat her pre-illness, that was about 3 months ago. And along with poor appetite, she also feels a bit weak, and she thinks she may have lost some weight related to that as well. She does not have any other constitutional symptoms like fever and whatnot. And the rest of it, she's able to actually manage fairly well. On examination, she does appear frail, and I could not elicit any signs to suggest that she has evidence of fluid overload. In fact, if anything, she looked a little dry on clinical examination. A routine evaluation was done, including her blood parameters, and they were all right. Her LV function kind of stabilized at around 40–45%, and that was the case even at 3 months. So today we are trying to discuss appetite stimulants, particularly in reference to patients who are struggling with some medical illness. In this case, it is MI and heart failure, but we see it more commonly in patients who have cancer and whatnot. And we are trying to see how we address this complaint of poor appetite without any other overt symptoms. So what will be your basic workup for poor appetite? Is symptoms and physical examination sufficient, or would you go for investigations? Is there a sound pharmacological basis for appetite stimulants, or the most of drugs that we use in our clinical practice work as placebo? And that I'm assuming that my attendees do use some appetite stimulant in their in their professional practice. And if you do, what is your favorite appetite stimulant? And do you select your patients in which you would start a particular stimulant as compared to others? And what would be the dietary or behavioral modifications that you may suggest to patients like these or other chronic illness patients so that they improve their appetite as a general? So the discussion is mostly going to be focused mostly around lack of appetite and how to improve it, and if there are any medical illnesses that we need to address along with it. So Praneeth, will start with your opinion, and then I will take the opinion from rest of the house.
Yeah, good evening, everyone. So this patient, I would first try to see whether there is any organ dysfunction which probably can contribute to her lack of appetite. Sickness per se or any illness can lead to reduced appetite. More importantly, I'm interested in looking at her liver function test, because liver, if it is getting affected, appetite is lost. So whether patient has any liver related issues, and probably equally kidney issues, something like any chronic kidney disease and all, which I believe in this case is not there. Second thing that I would look into is whether there are any drugs which are probably contributing to the lack of appetite. Cardiology space, I would specifically search whether the patient is on digoxin. That can be one of the reasons. And sometimes usage of amiodarone, which probably again can affect liver and that can interact. And if there are any antibiotics which can probably contribute. And if they are there, I try to reduce it. Most of the drugs, I believe, have a common side effect of nausea, vomiting, and which may in turn contribute to lack of appetite. But these few drugs which I mentioned are something that I look into it. Most of the time, it is counseling on eating, on giving them the freedom of eating whatever they want. Because whenever there is a cardiac patient, particularly when they got discharged from a heart failure admission, there is a lot of restrictions which are already told, and which patients also try to take it onto themselves. So first thing, I kind of give them that freedom of choice to eat whatever you want, eat whatever you like it, and try to change it. The only two restrictions that you need to look into are one, salt and water, or else eat whatever you want. And I suggest them to kind of try different foods so that you can kind of test your taste buds, and probably that can change the pattern and help you regain the lost appetite. Something like trying a piece of cake, maybe a chocolate, some fruit, trying different flavors. These are some things which I suggest. Appetite stimulants, most of the time, I believe they work more of placebo. Really, whether how much it does it help, I really don't know. But most of the times that I use, sorry to take the brand name, but I use Aristozyme, which I believe contains some enzymes which may help in digestion and to certain extent helps in appetite. I don't know whether that really works or it works as a placebo. And sometimes some of the other multivitamin syrups which are available, either of them try to keep alternating, because most of the time patient will also come back that it didn't work. So instead of continuing the same, you probably I do probably change to kind of giving them that reassurance. I believe essentially they work as a placebo, and these are some of the behavioral modifications which I suggest in my practice. Anoop.
Thank you, Praneeth. To answer some of your question, I did not check LFT on this patient, which I should intend to. She is not on digoxin or amiodarone, and she was on antibiotics at the time of discharge. In fact, I kind of thought that part of her appetite problem that she complained earlier was probably related to antibiotics, and I thought that would improve as the time would pass. But now, since the antibiotics have been off for quite some time, but still she has got these so-called lack of appetite symptoms. And I think it's been a month or more now that she has taken any antibiotics. I would say probably more than 2 months. So rest of the points are well taken. I will continue my discussion. I'll invite my other attendees. If any one of you who is listening to this session, if you have anything to add, you can raise your hand while I invite other attendees for their impression. Dr. Srinivas Raju is here with us. He is a cardiologist at Care Banjara. Sir, if a patient who is recovering from MI or heart failure comes to you with a complaint that there is poor appetite, Praneeth gave his verbatim of how he will approach. Anything that you want to add to this situation?
Yes, thank you, Dr. Anoop. I think Dr. Praneeth has covered all the points quite well. The only thing is, you say she is coming from low socioeconomic status, and even her husband is dependent on her to take care of him. So, if the number of medications what she's taking, if she's not able to afford all that, we need to rule out some financial stress which could be causing some underlying depression. Even depression also sometimes leads to decreased appetite. And then if we choose an antidepressant also, we should choose an antidepressant which doesn't cause anorexia further. And in your history, you have already ruled out anything like oral pain or oral ulcers or dysphagia or something like a gastritis due to polypharmacy, which could be contributing to the decreased appetite, or rather her avoiding increased intake because of other pain related issues. So if this has been excluded by your history, and if depression has been ruled out, I think most of the points Dr. Praneeth has covered it well.
Thank you so much, sir. I think the two things that you mentioned, I'll just highlight. So I didn't intend that she was financially weak. I intend to say that she didn't have social support. Finances were less of a problem for her. She was just living with her husband. Her husband wasn't really sick. It is just that the family dynamics was such that she used to take care of her husband rather than husband taking care of her. So that was the only family dynamic. Her kids didn't live locally, so they didn't have any physical support. I didn't perceive money as the problem to her. And then you mentioned about depression. I think that is absolutely well taken. And this is something I think we as a cardiologist should be sensitizing ourselves more than what we currently do, because in a lot of these situations, it is depression which may be manifesting in various symptoms, including poor appetite. So absolutely point well taken. Santosh writes a comment that iron deficiency with or without anemia is well documented in heart failure. Treating iron deficiency is big stimulant for appetite. So Santosh, your first point is valid. Your second point, I don't know. So the idea of iron deficiency without anemia in heart failure, there has been innumerable papers now which has supported this hypothesis that patients who have heart failure, even if they don't have anemia, their iron deficiency should be aggressively corrected because that improves their overall well-being, including heart failure. I think that part is well covered. Whether treating that iron deficiency will lead to appetite stimulation, that I don't know. There may be data behind it. I don't know the data. If anybody knows about it, please share your thoughts on it. Okay, I will continue my discussion. I will invite my other attendees. In fact, Dr. Praveen is joining us after such a long time. Praveen, if you can hear me, could you please unmute yourself and share your thoughts? Praveen Nagula.
Good evening, sir. Good evening, everyone. Sir, coming to this case, I would first consider as she is not well taken care by the family members. First thing is the what you call the self realization. That is, she might be thinking that if you take the usual regular food, again she might land up in the cardiac problem and such issues. The depression aspect should be considered. And the next one would be the polypharmacy, because she most of the cardiac drugs can decrease their appetite and all that. Regarding the appetite stimulants, I would be considering the aristozyme, sir, just Pranit sir has said, and the other one would be an unionzyme. And the other thing would be just shifting the drugs of the cardiac drugs as per the daily routine, rather than that of the usual taking in the morning, taking in the afternoon, and all. Just adjusting the cardiac drugs as per the daily life of her would suffice the problem if the cardiac drugs are found to be causing the decreased appetite. Probably if this patient NSTEMI, she might be on an antibiotic because of her previous illness. So most of the time when the antibiotics are used for more than 4 weeks, it is advised that if it is used for more than 2 weeks, you should also be using prebiotic and probiotic, so that the bacterial flora, whatever is there, will be there and will be preserved, and they will be causing the preservation of the appetite that usually they tell. So if the patient is not on prebiotic and probiotic, I would be advising that, and I would be using the appetite stimulants.
Thank you, Praveen. So few points that you mentioned. One is the use of probiotics, polypharmacy. I think these are well taken. To move around the medications from morning till evening, that certainly I think it's a low risk, low impact exercise, whether it will have any significant impact or not, but certainly it won't hurt. So that is something that that definitely can be tried, putting into this. The psychological part that you said, that patients may actually be self-restricting their diet, thinking they may get into trouble. That point also, I think, deserves an extra attention. It is very difficult for me whenever I'm discharging patients from acute illness, because at that time, they are most receptive of so-called dietary restriction. Post-MI in the discharge, the very common question that patient asks is, what are the diet restrictions? And they often get surprised when I tell them that there is no diet restriction for the first 6 weeks till you recover. And at times I understand that it goes against the patient's established thought process that if you are sick, then you should be getting dietary restrictions. Because, and I believe, and Dr. Radha and other people, they can probably correct me in that, that early in the course of recovery, it is very difficult for us to justify a short-term so-called dietary restriction, except in the scenarios where it is immediately going to hurt them, like fluid and salt restriction or sugar control when patient is admitted with abnormal sugar. So those are exceptions. But other than that, for most part, short-term dietary restriction may actually cause more harm in terms of poor appetite and decreased protein intake, which may impair with healing. So that I think is extremely important, and at times we may have to take a lead and tell the patients that if you are restricting your diet, please don't do that. On the same line, Dr. Srinivas adds that adding salt and fat to the diet may improve satiety and taste. I think that can also be promoted from our side when patients come, in case if they are not in heart failure, that we can tell them that adding a little bit of salt and eating a little bit of fat in their meals on the short term is probably not going to hurt. Definitely in the long term, we should talk about dietary modifications in those patient subset. May I invite Dr. Shankar, sir, what is your opinion about this particular topic from a physician perspective? Shankar, sir. Okay, maybe Shankar sir is not able to hear me. We'll move forward. Anybody else has got any thoughts to add before I ask Dr. Radha for her opinion on this topic? There is one attendee whose name is their phone as Nokia 3.1. If you could please rename yourself so that I know who you are. or send me a message so that I can identify you. Dr. Radha, if this patient has to come to you, how would you take up this case, particularly in relation to dietary modifications and also behavioral modifications, and what you can suggest clinicians like us, do's and don'ts, so that we don't impede in patients' appetite? Dr. Radha.
Thank you. So good evening to all. And thank you so much, Dr. Anoop, for giving me this opportunity to share whatever experience I have in treating patients with diet. Yeah, it's a nice case study. And this goes back to say, it's a multidisciplinary approach which we have to do. Loss of appetite, what your patient has complained, doesn't start today or yesterday. It starts from the admission. Yeah, that's because there is always this brain gut connection that is there. What happens in the brain is always affected in the gut, and loss of appetite is the primary thing or response that happens to whatever negative stress that is happening in this patient. So this is something that you already covered, but let me tell you one thing. What we have to do with patients who get admitted in the hospital is, how can you stabilize their intake during the hospital stay? That's most important. That's what is a primary duty of a dietitian, that address the adequacy issues, address the balanced diet issues that exist or prevail in a particular patient during admission or during the hospital stay. Once that is done, a dietitian's visit at discharge has to be made compulsory. She has to at length spend time in trying to explain what the diet is, provide a diet chart, not a printed one. Please, that is one thing that I keep telling in most meetings, that it should not be a printed copy, because that is what is administratively very convenient, but it does not address all the doubts that the patient has. So when I say admission, let me tell you the protocol generally that is followed by a dietitian, should be followed by a dietitian, is at admission, a 24-hour recall of the patient to know their dietary patterns is always should be taken. And that should reflect in a discharge diet, that this is their dietary pattern. Make small modifications to which it would fit to their medical condition and give them at discharge. And have we addressed the protein requirement during hospital stay? Because that has an impact on appetite after. Because malnutrition, because you said in your talking that she looked frail, malnutrition itself can lose appetite. So that's a vicious cycle where one after the other they begin to follow once we know that the patient is malnourished. During the hospital stay, did we stabilize the micronutrient requirement in terms of, let's say, optineuron, or trace element requirements in terms of zinc and selenium? Because these are most often deficient in patients who are hospitalized. If you have addressed that, then how did you take it forward during discharge in addressing it through the diets? What did we do? What was a protein supplement given to somebody? Was malnutrition identified at admission? Then did we correct it and continue it at discharge? What was it that we add on to what is called as aggressive nutrition therapy that we give in terms of an oral nutrition supplement? If your intake is poor, please take this as a second-hand, advice. It's something that we can always put there, because that is an oral nutrition supplement which is scientifically made with, energy, protein, vitamins, minerals, sometimes trace elements are there. So these things make it. And coming to a pure diet, if she doesn't have the taste, are we telling her choices like having a hot soup? Can she have something little sour? She can go back to normal, except for salt and fluid restriction, as you said. Did we include an amino acid powder? Something like glutamine does improve the appetite in these patients. Did we say instead of plain glutamine, can it be oral glutamine with zinc and selenium at least for a week? That can help. So these are small strategies from diet point of view, which we do advise, or at least per se, I do advise to see that patient becomes more or less normal or sustainable to switch over to a normal diet, which, they're going to. And then, are they physically active? Physical inactivity is something. Are they mobile? Are they moving around? Because that's another thing which kind of reduces the appetite. Is she moving around, or except in the wheelchair? What is it that she's actually involving herself in the house? These are small things that we can discuss upon and see whether they add value to kind of her mindset, and also make her more busy throughout the day, that she can actually shift her focus from not thinking that she's unwell. So these are small points. I don't know. Again, it is percentages of carbohydrates, protein, fat. These things play a real big role in correcting whatever small deficiencies that she may be having temporarily. I think that's it from my end.
Dr. Radha, I heard you very patiently. There are a few questions that come to my mind. So
Yes.
correcting deficits is one aspect of it, and I don't think there is any second thought to that. We should be correcting the deficits. I'm going to ask you particular questions with regards to appetite as a general. And there may not be a clear-cut science behind it, but I'm going to ask anyway, just to get your impression. Do you think protein energy malnutrition by itself will reduce appetite?
Yeah, one thing is, yes, it will.
Okay, so
because once you are protein energy malnourished, then you get into this vicious cycle of losing appetite, losing interest, and you kind of feel weak, and then weakness will pull you back to, or there could be some muscle aches or lethargy. All these are mentally driven, so it kind of has that gut brain axis that is there.
And extending and going beyond that, it would make sense that if you correct that protein energy malnutrition, then their appetite should improve. Is that a correct?
It will. Yeah, it takes about at least 4 weeks of time till you really observe them and see whether their intake is good or bad. From a 24-hour recall, you'll generally know how their intake is. If they're able to meet their nutritional requirements at least by 75% of the recommended amount, which we just calculate in a minute's time, that means she's going to do well. If it is less than 50%, that means she's not doing well, and loss of appetite is the primary thing. As somebody said, that iron deficiency, because that is again another deficiency counterpart, and loss of appetite is a symptom that you see in most deficiencies, not just iron deficiency anemia. And malnutrition is a total thing which kind of encompasses all these aspects, whether it is vitamin deficiency, whether it is mineral deficiency, trace element deficiency. It could be anything, or just a protein energy malnutrition.
So that was my second question, which is that micronutrient deficiency also would contribute to poor appetite. That was my second question,
exactly.
that you answered already.
Yes.
In all of these patients who are deficient, my guess is the intervention would include supplements rather than just telling them about various food items. Is that correct? Do you think most of the patients require supplements?
Yes, we need to have a practice change. Let me, as a dietitian, tell you all that in hospitalized patients, the very fact that they were hospitalized itself brings down their appetite, because nobody likes to be hospitalized, and they're there. And then it's a trauma for the patient and the patient family. And they have to go through that. They do develop courage during the admission, during the hospital stay, but then they have gone through. So that affects their appetite a little bit. And what we have to do is, during these times, a regular homemade diet or a wholesome diet does not provide the enough requirements, because their intake is affected. They do not have 100% intake, which was normal probably before admission or sometime before. So in order to meet the requirements, it's a temporary solution that you need to. There are a lot of scientific studies which have said that oral nutrition supplement would kind of complement the regular diet to meet the nutritional requirements, so that the overall improvement of health happens in discharged patients or hospitalized patients. So that is what is an essential component.
Right. And did I hear you correct when you said that amino acid powder like glutamine, other than being a protein supplement, can also stimulate appetite? Is that what I
Yes,
heard?
yes.
Is that what I heard?
That is something that glutamine has a number of functions inside the body, and then there you get this glutamine powder plain. You do get them, with other thing. There is something which you get along with zinc and selenium. So that can be advised for a week. See, I'm not telling for life. It is just a sachet for a week would help them get their requirements to a certain extent, and probably help in correcting loss of appetite, or that basic lethargy that is there, or the feeling of weakness that is there in them can be corrected.
Thank you, Dr. Radha, for that exhaustive note. We will move forward. I will ask Dr. Shankar, sir, your thoughts on whatever we have discussed. What do you want to add on it?
Good evening to all. Sorry if problem with the network. Generally, how I approach to a patient of, if time permits or if with your kind permission, how I approach to a case of a poor appetite or loss of appetite patient in a nutshell. Can I proceed?
Yes, sir. Please go ahead. If you could just summarize your thought process, I think.
Only.
Sure.
So I made it into the causes of poor appetite or loss of appetite. Then what are the investigations we are supposed to do, and arriving at a provisional or final diagnosis. Then management, lifestyle, and the supplements and medications. So this is my this agenda. But if time permits, Dr. Radha already touched upon many factors of diet and all. So whenever a patient of poor appetite or loss of appetite, here index case is also there. So then we think of gastrointestinal causes like gastric cancer, hepatitis, hepatic metastasis, chronic liver disease, infections or intercurrent illnesses, especially in this pandemic era. Most of the patients with COVID, they will have, apart from loss of smell and loss of taste, they also complain of loss of appetite also. In the long COVID also, in the long haulers, also having this loss of appetite. So HIV patients, we come across with most of the patients, they complain of loss of appetite, whether with the disease or with the medication. The metabolic causes, we have to think of Addison's, hypothyroidism, hyperparathyroid, hypopituitarism, and the medical or systemic conditions like chronic kidney disease, chronic renal failure, chronic heart failure in this case, and COPD, and cancers. And psychiatric problems like depression, eating disorders, anxiety, medications, especially chemotherapeutic agents, antibiotics, digoxin, diuretics, antihypertensive medication, narcotic analgesics, amphetamines, all these cause anorexia, loss of appetite. And age itself, as age advances, our appetite also goes down. And functionally also, we feel sometime we'll have a poor appetite or loss of appetite, looking at the unpleasant sight or smell of the food. Then miscellaneous causes are there like smoking, abuse of alcohol, thiamine deficiency. This has to be very much stressed because in the this thiamine deficiency, if it is corrected, the appetite will be improved. Then not concerned here, but early pregnancy also, they come when they complain of poor appetite, loss of appetite, they have got missed periods, they should be investigated for pregnancy. So having gone through all these causes or etiology of the poor appetite or loss of appetite, depending on that, we investigate. I don't want to go into details regarding complete blood picture, liver function test, renal function test, ultrasound, abdomen, and upper GI endoscopy. So many things are there. According to the cause, we have to investigate further and arrive at a proper or a provisional diagnosis. Then the management of appetite patients. First of all, I divide it into lifestyle changes and supplements and medications. The supplements are already touched upon by Dr. Radha very well, like zinc, selenium, and glutamine. To that added, thiamine. Amongst the vitamins, thiamine, even if the patient is not deficient also, thiamine helps a lot in this case. The omega-3 fatty acids, whether this I stress very much to my patients, this salmon fish, if it is available, rich marine-based omega-3 fatty acid, among that salmon fish, if you relish it, Dr. Somar Hazu sir might know better than me. Salmon fish, it definitely gives a lot of omega-3 fatty acids, increases the appetite too. Suppose if he is a vegetarian or vegan, then we can go for even algae-based omega-3 fatty acids also available in the market. So, and second thing, apart from these supplements, especially in my practice, I give bitter herbal extract syrups are there, available in the market as Activate or Aptispur. These bitter herbs, they stimulate the appetite. Especially they contain cardamom, pepper, cloves, garlic, ginger. All these things will be there in this natural naturopathy or Ayurvedic preparations. So they contain guduchi, saunf, kutki, vidong, nagarmoth, zira, pipal, amlaki, yavani, nimbuka. So all these ingredients will be there. These are all what I mentioned in Ayurveda. They are appetite stimulants. Especially, I give my patients these herbal extracts in the form of syrups. So, having known about these supplements, lifestyle, I give a lot of importance to. In the case of poor appetite, loss of appetite, and the tips and tricks are there to stimulate the appetite. And especially, I tell the relatives that be supportive, not pushy. And healthy balanced diet, which is touched upon, offer whatever we offer, there should be smaller frequent meals, 6 to 8 times instead of 3 larger ones. And in between snacking also, where even the patient is not hungry, we have to encourage snacking. And the snacking in the form of just now mentioned about Ensure, even Boost, soya milk, sweet fruit crunch, juices, nuts, seeds, even flax or chia seeds, pulses, legumes, cheese rolls, yogurt, peanut butter. These are all snackings which can be encouraged. The smoothie is also there. And offer a favorite nutritious food. And prepare food colorful and appealing to eye. And the patient should be stayed well hydrated. Make meal times a social event. Eating with the friends and relatives should be encouraged. And watch a favorite television show. While eating also, better we should encourage his favorite TV program or a movie. And a little exercise to be encouraged. And meditation, talk therapy, that gives stress relief. The sleep hygiene, which was discussed in the earlier adult session, the sleep hygiene to be followed here and makes sleep a priority in all these cases, lifestyle changes. So having known about these lifestyle changes, a few of the medications are also there, which are FDA approved. They are especially, we give in cancer patients, where patients on chemotherapeutic agents and HIV/AIDS patients, we give megestrol acetate that is available as NDAS or Megase. It comes as a pill or liquid form. 160 milligram tablets are there. We give up to 400 to 800, especially in breast cancer and endometrial cancer patients, HIV/AIDS. This is a very good appetizer. At the same time, it increases the weight too. And other drug approved by the FDA is the dronabinol. That is, it is a cannabinoid preparation. It is available as a marinol that can be given. And anabolic steroid like oxandrolone. It is available as oxandrin or anavar. So these three are approved by the FDA, and other off-label medications are also we use in our clinical practice, especially this mirtazapine. The patient has got little amount of depression is there. We should encourage taking mirtazapine 15 milligrams per day. And other things, especially in cancer patients, we give steroids also, prednisone, decadron. That also increases the appetite. And the cyproheptadine, this also is a very good appetizer, appetite stimulant. Cyproheptadine along with the sorbitol or lysine, available in the market as Peritol G or Cipel. They can be given to the patient if the patient complains of poor appetite. So here in this index case, elderly lady, because the age is also more, then the chronic illness is there in the form of MI, and she has got heart failure, and she's already on medications, like might be on diuretics. If she is hypertensive, antihypertensive, dioxin is not advised nowadays unless a real indication is there. And psychological depression, anxiety, these all contribute to poor appetite, weight loss, and fatigue too. So, as I mentioned here, I first prefer to go for the lifestyle changes, then supplements in the form of zinc, selenium, and glutamine, as Dr. Radha has mentioned, omega-3 fatty acids, then digestive enzymes, then herbal stimulants in the form of syrups, then cyproheptadine and mirtazapine. These will help this patient to overcome this poor appetite or loss of appetite and fatigue, weight loss, and everything. Thank you, one and all.
Thank you so much, sir. That kind of covered most of what we should probably know about this. I'll ask Dr. Sainath, because Dr. Sainath probably deals with this problem more than any one of us. Dr. Sainath is a medical oncologist at Care Hospital, Banjara Hills. Sir, thank you so much for spending your time with us. If you could unmute yourself and share your thoughts regarding your pharmaceutical management or behavioral management of anorexia in your patient subset. Sainath, sir.
Yeah. Thank you, Dr. Anoop. I think the previous speakers have clearly elaborated the broad management of this problem, which we often encounter in our clinical practice. So here we see these kind of problems in two sets of patients. One, in patients where the intent is curative, and especially with the tumors of the gastrointestinal tract and ovarian cancers, where the disease is in the peritoneum and everything, when we are treating with a curative intent during the time of therapy, I think more importantly, it is nutritional supplements of micronutrients and these things. And while these patients, when they are on chemotherapy, the biggest problem is the loss of taste and the will to loss of appetite due to the chemotherapy drugs. So rightly, we start with the behavioral modifications of small meals, frequent meals, and with some taking lime, smelling lime, lemons before starting your food, all these kinds of stuff. And most of the time, with just behavioral modifications and positive feedback and reinforcement, most of these patients they do take good. Coming to the protein supplements for these patients in adjuvant patients, I think we have to be very cautious. What we have seen in clinical practices in patients who have tumors in the GI tract and ovarian cancers, abdominal cancers, there is a problem with nutrition. But in patients with breast cancer and them, generally, even though there is loss of appetites, conservative management without any pharmacological therapy or protein supplements is sometimes good enough. Lot of patients, breast cancer patients, do actually put on weight during chemotherapy because of the steroids and the overzealous nutritional supplementation which they take. Now, coming to the palliative patients, where the intent is only to provide palliative, here most of the time we end up using pharmacological intervention. And the most common drug which we use is megestrol acetate. And it is actually this is a very big problem with, again, gastrointestinal cancer and ovarian cancer patients. And also when there is a significant liver mets, where the burden of disease is high and the patient has severe cachexia and sarcopenia. In these patients, again, apart from the nutritional supplements, megestrol acetate, small short course of steroids actually helps them to take some amount of appetite. Again, here the backbone of treatment is always, if you have a very good systemic therapy available for the patient, they are likely to improve their appetite over a long period of time. And these till that time, these act as adjuncts to therapy. That has been clinical experience. But largely, I think when we talk about nutritional management, it should also be guided with the site of the tumor, because a breast cancer patient on adjuvant chemotherapy, actually more than behavioral modification and certain these things reinforcement, we may not actually end up giving so much of pharmacological therapeutics. Whereas in GI cancers and where there is significant tumor burden, again, pharmacological intervention has been required. That has been our experience. Over to you, Doctor.
Sir, I have few questions. Other than megestrol, are there any other approved therapies available in India?
Actually, megestrol is one. Short mirtazapine is available. Again, now one of these companies has launched cannabinoid oil. So this, even though the data is not so strong for this one, probably this also helps in a few of patients who don't respond to megestrol. But megestrol is available, which is most commonly used. Steroids is something which we use, and the other thing is mirtazapine is something we occasionally use. Cannabinoid is coming into the market.
So second question is, do you see these other appetite stimulant drugs, like somebody spoke about Activate, which is a herbal compound, and then Praneeth spoke about Aristozyme and all this. Do you think these things you guys end up prescribing to your patient? Does it work? What is your
a lot of time it is a trial and error kind of a thing. You start with all the regular stuff, and something if doesn't work out, you start introducing all these Activate and Aristozyme. Also, it only helps in marginally, like pancreatic cancer patients and patients who have upper GI malignancies. In these patients, Aristozyme seems to work very well. And Activate also, the herbal one which is available, it acts as adjunct in some patients. Largely, it is when in an advanced cancer patients, until and unless the disease is controlled, the other things don't improve. For adjuvant patients, it's only for a short duration of time. It is mostly the micronutrient management in the patients whom we are treating with curative intent. Surgery has been done. They have to go through only for chemotherapy for some time.
And then last question to you, sir. Magistrol is something that cardiologists are not that familiar with. If you could just give us your tips and tricks, do you think this drug can be used in cardiology subset? And what kind of problems you face with this drug?
See, right, very important for the cardiologist to know with this magistrol acetate is slight increase in the risk of venous thromboembolism. So, but in patients with advanced cancer, where the intent is palliative and the focus is on good quality of life, in those patients, we do accept that risk. And sometimes most of these patients who are at anyways high risk at risk of venous thromboembolism, we do keep them on prophylactic direct oral coagulants. That is there. Second thing is the dose is, like sir said, 160 mg tablets is available. You give it twice or thrice a day. But the other common clinical encounter which we see is, again, some patients do complain of an abnormal abdominal discomfort, which is also, there is also some amount of nausea also adding to it, which is more common in clinical practice. So not everyone will tolerate the drug as well. Not everyone will tolerate it very well. So it's again, we try it out in patients. I try it out only in palliative care setting, not in adjuvant setting. And venous thromboembolism is one thing one should actually keep in mind when using magistrol acetate. What is their baseline risk of any venous thromboembolism? For cardiologists, it would be very important.
Right. Thank you, Sainath sir. We have few more minutes left. May I ask Somaraju sir to give his opinion about today's discussion and how does he manage? How do you manage, sir, your patients who have poor appetite?
Good evening, everybody. Thank you, Anoop. I learned a lot of things from what is already talked about, but I'll just stick to this patient's issues. Is she a diabetic?
Yes, sir, she is a diabetic.
She is on metformin?
She is on metformin, yes.
Yeah.
But low dose. Low dose.
Number one, I must make a general statement. In a situation that you talked about in patients like this who come to us, I never had to resort to appetite stimulants, almost never. And number one. Number two, polypharmacy, Dr. Praveen already pointed out. The commonest cause is polypharmacy and also some of the drugs. Some of the drugs we give, like dual antiplatelets, aspirin, antiplatelet plus statins, these combination drugs often produce more gastrointestinal irritation, gastric irritation than given alone. And those things have to be addressed too. Then having said that, depression is extremely common post myocardial infarction and post ICU stay and living alone and these COVID times, etc. Even without all this, depression is extremely common after myocardial infarction. Having said that, it's important, I'll only stress on one thing, how we counsel taking care of this polypharmacy and the combination drugs, metformin, etc. Having taken care of it, how we counsel them matters. Number one, in any given situation, give the patient, say, what is the good news about all this? Suppose the patient has, depending upon the clinical diagnosis you made, say post-myocardial infarction. Tell them the advances in drugs and the best drugs available now, how they prolong life, etc. And the technology available and the devices available. And also give them the examples of some famous people all around in the world or in the communities after similar illness, how long they lived, how some of them are living longer even now, and those things do help. And Medistrol we should never use in cardiology. And I will leave it at this because most of the things are already covered. How you counsel them matters. Give them the good news in that bad situation matters. And if you look at the drug trials of varieties available now, there are so many drugs that you have to give for patients with heart failure and coronary artery disease and diabetes. Polypharmacy is a rule, and that is the commonest cause for loss of appetite, etc., in a general patient. And having said that, you have now empiric trial also. You have one more drug to add in heart failure, and to the extent now people want us to believe that patients with heart failure with all these drugs live longer than normal people. Thank you.
Sir, just one last question. You did mention about metformin. We know that metformin is certainly an appetite killer. In fact, I have two questions for you. Do you think a low dose metformin, like in the doses of 500 milligrams once daily, which sometimes is combined with SGLT2 inhibitors that has been used in heart failure patients, should we be very stricter and get rid of metformin altogether? That is question one. And question two is what Praneeth put it in the chat box, that hospital food is appetite killer in itself. Do you think there is a need for a change or a shift where we should be redesigning how we provide food to the patients who are admitted in the hospital?
Second question I'll come to later. Metformin is not a contraindication here, but each individual patient is different. So give a trial of stopping metformin. I am not saying don't give metformin at all. Any dose, stop it temporarily. That does make a difference, particularly in elderly people. And actually on metformin side effects, most of the gastroenterology survives now. They do all sorts of endoscopies and they never ask the patient to stop metformin. And second issue is the hospital foods is not something that you can change overnight. And hospital food, having gone home, is the issue. While the hospital was a different issue. This patient went home and still doesn't have a good appetite. That is the issue.
Shankar sir, you have something to add, final words?
Regarding the Magistrol, sir has told already that is really it is contraindicated in many other conditions of cardiovascular disease. Apart from that, it causes a stomach upset and mood changes will be there. And sleep problems also will be associated with the Magistrol. And regarding cardiology concern, it causes sodium and water retention. Already this patient is having heart failure, so it aggravates. And it worsens the diabetes, this Magistrol. So already patient is a diabetic. So, and above all, and it causes coagulopathy. It has been mentioned that the DVT, pulmonary embolism, other coagular, this thrombosis, thrombotic episodes. So in this patient, Magistrol is highly contraindicated. If at all, the patient complains of some amount of nausea, we can give metoclopramide for a short period, at least for 1 week. That improves the appetite. At the same time, it relieves the nauseating sensation with the polypharmacy.
Thank you so much, sir. It is 8:03. We may actually stick around for 1-2 more minutes and then we can close it. If you have any of the questions or comments, you can either type it in the chat box or raise your hand. I'll give you a chance. Somaraju sir, I do have one more question for you. During the discussion, I did mention about dietary restrictions in a recovering patient. And I personally believe, without any science backing, that patients who are getting discharged from the hospital with a cardiovascular illness, I can talk about cardiovascular because that's the kind of patient I'm seeing. At the time of discharge, I typically tell them there is no need for any aggressive diet restriction for the first 4 to 6 weeks when your body is in the healing phase, except for those restrictions which are immediately threatening to life, like sodium or water or sugar, in case if patients have uncontrolled diabetes. In those patients where diabetes is reasonably controlled, I tell them you don't even have to restrict that much sugar as well. Do you think, sir, this is a rational practice, or you think I'm getting too pragmatic and I'll get in trouble in terms of clinical syndrome? What is your thought on this?
I agree with you in everything except sugar.
Okay.
Sugar is poison.
Okay.
Salt is far better than sugar. And you have to be moderate in everything we advise and go by individual patients. But do advise them not to use sugar, not even sugar substitutes. Thank you.
All right. Thank you. Thank you so much, sir. If nobody has any other questions or comments, may I ask Praneeth to give his closing comments?
Yeah, no, a very common topic with a lot of information. I still can't say that there is a one quick fix, but many suggestions which have an impact on a long term. Talking about polypharmacy, behavioral patterns, putting some effort on ruling of depression, which is kind of prevalent than we estimate or think of. So holistic approach on doing all these things and probably spending more time with the patient goes a long way in knowing the patient better and catering to the needs of the patient to help them get their appetite back and making their lifestyle changes that probably should help them lead a happy life. Yeah, no.
Thank you so much, Praneeth. Thank you, Sainath, sir, for sparing your time. I thank all of you for attending today's session. I want to remind all of you that we are on a WhatsApp as a Huddle group, where we do discuss offline these topics and also upcoming topics. If you do desire to be a part of that WhatsApp group, the link is there in the chat box. You can simply click. Also are the links for the archives of the previous episodes that we have recorded. They are there on podcast on YouTube, which you can listen to later on during your dead time as well. We will be back next Wednesday with 82nd sessions of the weekly huddle. If you do have a topic that you think we should be discussing in our future huddle session, please let me know or share it in the WhatsApp group, and we will try to find a way to fit it in there. Thank you all for attending. Good night. We will see you next Wednesday.